What is going on, everyone? This is Dr. Josh Funk, and you are listening to the Strength and Knowledge Podcast.
What's up, everybody? This is Zach Baker, and we have our guest, Christian Huckfeldt, one of our sports residents here at R2P. Hard to believe, but we are over halfway through the residency, and we are just wrapping up the month of March right now. In the month of March, the educational topic in our residency is the elbow, wrist, and hand. Christian's one of our baseball guys, so baseball is a big passion of his. Played all his life, played collegiately, and has continued to go down that route from a clinical expertise and really just one of his clinical passions of the patient populations and types of injuries that he likes to treat. So this is part of our Journal Club series where our residents find an article in relation to the topic that we're discussing. So, Christian, do you mind just letting everybody know what the article was that you chose and your rationale for choosing it?
Yeah, absolutely. So the article I chose was called "The Role of the Flexor Pronator Muscles as Dynamic Stabilizers Against the Elbow Valgus Stress in Patients with Medial Ulnar Collateral Ligament Insufficiency." If you can say that 5 times fast, that's impressive right there.
I was going to say, I don't think you could have picked a longer article title to choose. Why did you find this one interesting? And fortunately, like ACL and some of our other sports medicine injuries, medial elbow pain, UCL injuries, they do tend to have a lot of literature or just a lot of focus in the literature geared around them. How did you come across this article, or what made you want to pick it?
Yeah, absolutely. I think, like you had mentioned, there's a lot of literature just about UCL injuries in baseball specifically. But as we can see over the past couple of years, there's a lot of literature that started to come out around the role of flexor pronator injuries, either in isolation or combined with medial elbow UCL injuries. And this article did a really good job of highlighting how close in proximity and importance those two structures are.
Yeah, and I'm excited to get into this article because when we talk about throwing, we know the medial elbow takes a lot of stress. We know the flexor pronator muscle group has a large demand in throwing. In school and coming out of school with patients, in my mind, I was always kind of playing the chicken or the egg game of, are we having medial elbow pain because we lack flexor pronator capacity? Are we having flexor pronator issues because we lack elbow stability? Is there a correlation? Is there a cause and effect? Or do they just conveniently tend to be anatomically next to one another, so they often get injured at the same time? And I'm hoping this article can give a little bit more insight in regards to what is the role of the musculature with help combating insufficiency of that UCL ligament, and then ultimately figuring out, like, how does that guide clinical care from a prehab or a rehab standpoint. So, Christian, do you mind going just into the article? Give us kind of a general idea of how it was laid out. What were they hoping to find? And then after that, we'll dive a little bit deeper into like what they actually found and what we can take away from it.
Yeah, of course. I mean, I think just really quickly before I dive into the article, just quickly in the background, if you're not familiar with the pitching motion and you're listening to this podcast, in the late cocking or early acceleration phase of pitching, so basically when the pitcher lays their arm back into maximal external rotation, we tend to see a lot of elbow varus torque at the elbow, meaning that's elbow valgus stress. And so there's two structures primarily at the elbow that help to absorb some of that stress. One is passive and one is dynamic. So the passive structure is going to be that ulnar collateral ligament, or the UCL, which is frequently injured when we hear of Tommy John surgery. And then the second is the dynamic structure, which is the flexor pronator mass, which sits right on top of the medial epicondyle and literally sits right almost on top of the UCL's origin. So really, I think that kind of answers the question that you had earlier, the passive and the dynamic structures and how closely those two structures are intertwined.
Now, I'm glad you cleared that up, and I think another easy analogy to think about that from like our lower extremity counterpart is, I think this article is going to go down the same role of when we have an ACL injury, how much should we care about maximizing quad and hamstring strength, either from a preventive state or from a rehabilitation state? And I think you hit the nail on the head. We need to think about active and passive stabilizers, Does one precede the other? Do we focus on one more or the other? If one is lacking, how much ground can we make up with the other one?
Yeah, exactly. So this study in and of itself, they took individuals who had a UCL deficient elbow and they placed them under maximal elbow valgus torque. And then they looked at whether isometric contraction of the flexor pronator muscles changed their pain at that level, but also the medial joint width itself. So they really looked at the joint structure as well as the pain. So the participants included 18 baseball players that came in with complaints of medial elbow pain. They had a positive clinical exam, meaning they had a pain with the milking maneuver or the moving valgus stress test. These individuals were then sent for an imaging, either an MRI or an ultrasound, to confirm the presence of medial elbow pathology. So of the 18, most were primarily in high school, 17 to 18-year-olds, but there were a couple who were a bit younger, and there was one or two who were college, and one was professional as well. But that high school level is really the level which we're talking about. So of the 18 of them, 11 had partial UCL tears, 1 had a full UCL tear, 4 actually had a chronic apophysitis of the medial epicondyle, so we're looking similar mechanism of injury, just different structure. And then the last 2 individuals actually had avulsions of the sublime tubercle, which is the UCL's insertion onto the ulna.
Good. So I think it's always nice when you have studies that try to paint the picture for individuals of clinical presentation and structural integrity via imaging. And I think that is always a very tricky dynamic to navigate when you have somebody that's coming in, they're expressing pain, they're expressing some functional impairments. And if you do not have imaging, trying to figure out, does this warrant a cause for imaging, or is this something that we can work through on our own? And hopefully when we get into the role of the dynamic stabilizers, starting to tease out if somebody does present with laxity or somebody does present with pain, what's our ceiling for rehab potential? And is this something that we can rehab our way out of? Or should we be referring out for imaging just to see what we're working with from a parts and pieces standpoint so we know what that ceiling for potential is? Because the throwing motion is very unique. It is very violent. And you can only modify it in so many ways that are going to reduce the stress at the elbow. So we do need to make sure that we have active and passive integrity there. And then how much of each we have, we can probably spend all day on that regarding of what we should look at. So
yeah, bingo.
What were the big kind of findings, conclusions, and takeaways on your part from this, Christian?
Yeah, absolutely. So real quick on the methods, individuals were placed supine 90-90 position on the table. The examiner laid back their shoulder into external rotation, so the farther they lay back, the greater valgus stress on the elbow. So the individual, their shoulder was laid back until they had pain at the elbow. At that point, it was stopped, and they looked at the medial joint width via ultrasound. So that was the part 1. Part 2, at that position, then they had them isometrically contract into forearm and wrist pronation, and they looked at, did the pain get better, did it get worse, or did it stay the same? And then also, what was the medial joint width under elbow or under pronation isometric contraction? So did that change at all with the isometric contraction?
And sorry if I missed this, but what was the position that they were doing the isometric contraction in?
Forearm was in neutral.
Okay.
Yep.
Thank you.
Yeah, so the results they found, unsurprisingly, the medial joint space was significantly wider on the injured side than their non-dominant or their healthy side. So it was about 5.1 millimeters on their injured side to about 3.2 on their healthy. So pretty significant. Additionally, during the isometric contraction, the injured side, the medial joint space actually closed up or improved by almost 2 millimeters. I think it was about 1.9 millimeters. Whereas the healthy side actually only closed up by about 0.6 millimeters, so really kind of 3 times more. But I think the most significant result is what they did is they looked at the individuals who's had that UCL deficient elbow under contraction parameters, so they were trying to stabilize as much as they could, but that was still wider, or that joint was still more lax than a healthy elbow at rest. So even if we are in this condition trying to isometrically contract the muscle as much as possible to close up that joint space, it still wasn't what the healthy elbow was.
Good. So the big takeaway that I get from that is yes, flexor pronator musculature can reduce the laxity within the elbow and help close down that space. In this circumstance, though, it is under maximal isometric contraction with all of their concentration and brain power going towards that activity. And then we could also get into the argument of, is this going to carry over with their specific arm slot that they're going to come out of? And if they're changing wrist position, degree of pronation, supination, maybe with how they are releasing the ball with a specific pitch that we're doing. And then all of the other external circumstances that come into play when we talk about like the environmental nature of which they would be doing this. So that's great. I think very good study. Let's open it up for discussion now. Like, Christian, what's your takeaway from this? And if you have somebody in the clinic that's coming in with elbow pain, with elbow laxity, let's break it into a couple parts. You're finding elbow pain. They're reporting elbow pain. You're finding elbow laxity and pain with your clinical exam when you're doing your milking signs, when you're doing your valgus stress test. They have not had imaging yet. If you're dealing with an athlete personally, what's your kind of framework that you go through of, do I think this person would benefit from getting imaging prior to me working further with them, or just in conjunction with me working further with them?
Yeah, I think that's a great point. At that point, if they are, especially if they have laxity, but significant pain as well with milking and with moving dynamic stress test, at that point, I'm going to refer out for imaging to a doc. I think there's definitely things that we can do from an orthopedic impairment standpoint as we're waiting for imaging, just to continue to improve the impairments that we see. But at that point, that's probably warrants at least a shutdown from throwing, or at least a significant drop in volume at the very least, and then a referral out to the doctor at that point.
And I have very, very similar thoughts to you on that with what you had just expressed. And usually how I'll communicate it to the patient as well is, yes, we want this from a diagnostic standpoint, but especially if you have a high school or a younger athlete, this can serve as a baseline measurement for what your elbow looks like now. And if you're going to continue to play 2, 4, 6, 8 years of competitive baseball, and especially if you're a pitcher, the likelihood of you potentially experiencing elbow pain at some point, whether it's mild, moderate, or severe, is relatively likely. So if we can at least get a snapshot of what that elbow looks like right now, then in the future, if you do have another flare-up or another re-aggravation, and they do imaging at that point, we can see what's the integrity of the joint look like from start to finish, and is this remaining static? Is it getting more progressive in nature? And it just gives you more information to work off of there. Getting back to throwing is not an overnight task as well. So there's, when you look at protocols, when you really just look at a sound, logical progression of what that looks like, it can take several weeks. It can take several months. So the last thing that you want to do with an individual is withhold potential information from them of getting it with imaging, take them through an extensive rehab program only for them to have pain. Now you're 2, 3, 4 months into this, you go get an MRI, the MRI does not come back favorable, and you realize that, if we would have known this from the beginning, we may have gone a different route with this, or we may have taken an extended amount of time off from throwing. Even if they're not going surgical route, we could have allocated our early rehab time in other more optimal and efficient ways, instead of trying to rush back, or not even rushing back, but taking like a shorter duration throwing interval program.
Yeah, exactly. And I think you hit the nail on the head, and especially if we're talking about younger athletes and younger throwers, especially like before they hit puberty and such. Any thrower who's coming in with elbow pain and is pre-adolescent or kind of pre-pubescent, I'm immediately referring out, because the first thing I'm thinking of is apophysitis, growth plate injury, hopefully not, but growth plate fracture. And now not only are we thinking of something that could be a little bit mild, but it could be more severe because of the growth plate involvement. So that's something that would definitely warrant an early referral for me. If they're a little bit older and it's something that they just had a little bit of mild elbow tenderness pop up, and that may be something I'm a little bit more, I would manage possibly a little bit differently, but the youngsters for sure warrant an immediate referral.
So our big take-home message, Christian, is we just ignore flexor pronators. They do nothing in the rehab process, right?
No. No, definitely not.
Can you elaborate a little bit on, we may not be able to negate UCL insufficiency and laxity with flexor pronator strengthening programs. We know we can influence, but we may not be able to completely mask it. What role do flexor pronators play? How much time do we allocate towards working with them? Or if you just want to elaborate on what are some strategies that you use to rehab this area in conjunction with just a good return to throwing program or just a prehab program for throwers?
Yeah, sure. So in terms of what role they play, I think they need to be trained. I think they are one piece of the puzzle. I'm not going to say that adding a few wrist flexion or a few wrist pronation curls a week is going to dramatically change your potential of UCL injury in the future, but I do think it is one piece of the puzzle. I do think it's an important piece. I think if we look at a lot of the older, I should say, throwing programs and strengthening programs like Throwers 10, you see a lot of shoulder and a lot of rotator cuff and scapular type of exercises, which is terrific. And I do think that's the meat and potatoes of what we kind of need to work on as a rehab community. But I think it would be remiss if we didn't at least train the flexor pronator group in isolation. And that could be from younger kids as easy as wrist flexion, wrist pronation, and some other things. And once we get into the higher levels, working on different grip strength, different types of holds, progressing into more plyometric type of activity. So I 100% agree. I think those muscles need to be trained in isolation for sure.
Yeah, and I like how you talked at the end of where grip plays a large role in training this. And I think we often, we always associate, isolated wrist extension, isolated wrist flexion, isolated pronation supination, which definitely plays a role in getting that area stronger and more tolerant and building its capacity. But you can work this group with a heavier level of resistance and a higher volume just through maximizing grip demands with some of your other activities. So I think of things like farmer carries and trap bar deadlifts, heavy dumbbell rows, things along those lines that are still, maybe the flexor mass and pronators are not the main driver of the movement, but they are required for successful completion of that movement. Having them do grip, like you had mentioned, in different positions of pronation and supination. And are we doing it with a palm up versus a palm down or a more palm in grip? Do we have a narrow or a thick object that we're holding as well? And having the actual hand placement being a little bit different can influence that. And then also with this, how much are we influencing maybe the ability to control wrist deviation versus finger motion? So are we doing more of your lumbrical grip or different pinch grips versus just a traditional hold that you would see with a trap bar deadlift or something along those lines? So you can get very creative with training grip, whether you're doing it in the clinic or doing it as part of a home exercise prescription standpoint. Christian, any other big takeaways from this or things that really just become top of mind for you when you think of this injury, this patient population, or just after finishing this article?
Yeah, absolutely. I think your last point there really hits the nail on the head in terms of the grip demands with trap bar deadlift and with rowing and with certain other exercises in the gym. I think it's just important that we consider this during the rehab process. So if I have somebody who's coming in early for maybe a flexor pronator strain and I want to maintain their lower body lifts and I want to maintain some upper body capacity, I need to be really mindful of the grips that we're using. Am I having this individual deadlift 350 from the floor? Well, that grip demand is going to be really, really high and may not be able to be tolerated early on. So those are the things that we need to think about in addition to training these muscles isometrically and isotonically as well. But understanding the grip demands with lower and upper body lifts, both during the rehab process and also in season as well. So if we think of the throwing motion in general, it is a upper body plyometric activity where there is a lot of flexor pronator activation during the throwing motion. So that means probably during season, I want to be mindful of the heavy gripping type of activities we're doing in the season. I'm probably not going to be doing heavy max trap bar deadlifts multiple times per week right before they go and throw a 100 pitch outing. That's not saying those exercises are bad or that we can't periodize them differently throughout the week, but just being mindful of the grip demands so that we're not leading these athletes to be fatigued in those muscles before they go out there and throw.
Yeah, I think that's a great piece to talk on is in-season versus out-of-season considerations. You could also look at it where maybe an individual has a lower volume week pitching and you want to maintain strength during the week, and that's a way to maintain strength with heavy grip without the demands of throwing. And the other good thing with grip activities is oftentimes your heavier grip activities have a large distraction component throughout the entire upper extremity, at the shoulder, at the elbow, at the wrist, which you're going to see large distraction demands during the throwing motion. So it's another way to train specificity of pitching qualities without just throwing in general. So, Christian, as always, appreciate you diving into the literature, filtering, synthesizing, and summarizing this information with us. For everybody listening, we appreciate your time and attention. And next month, we'll be diving into concussions.
Thank you for listening to the Strength and Knowledge Podcast. If you enjoyed this episode or have been tuned in for multiple episodes, we would love for you to subscribe, rate, and give us a review on Apple Podcast or Spotify. Until next time, thanks for listening.